It is now my pleasure to introduce today's first presenter, Benjamin Luzzi. Please go ahead.
Thank you, Stephanie. My name is Benjamin Luzzi. I am the Senior Advocacy Associate for the American Society for Healthcare Engineering at the American Hospital Association. Today's webinar is COVID Recovery, Pre-Planning and Immediate Needs. Today's webinar is being provided and will be recorded and made available to ASHE members and the general public for the time being. On the ASHE COVID resource website, actually on the recovery webpage within the COVID resource website. Recording, reproducing, or transmitting any portion of this webinar in any form or by any means, electronic or mechanical, including photocopying and digital recording, or by an information storage and retrieval system is strictly prohibited by the American Society for Healthcare Engineering. This information is provided by ASHE as a service to its members. The information provided may not apply to a viewer-specific situation and is not a substitute for application of the viewer's own independent judgment or the advice of a competent professional. ASHE does not make any guarantee or warranty as to the accuracy or completeness of any information provided. ASHE and the authors disclaim liability for personal injury, property damage, or other damages of any kind, whether special, indirect, consequential, or compensatory, that may result directly or indirectly from use or reliance on information from this webinar. At this time, I'd like to introduce our speakers today. So one of our speakers will be Robert Booth. Mr. Booth has over 30 years of healthcare compliance experience in infection control, industrial hygiene, and public health. His areas of experience include experience with the AHCA, the State of Florida Agency for Healthcare Administration, CMS, the Centers for Medicare and Medicaid Services, and the Joint Commission compliance, medical risk management, surgical safety, infection control, and employee health. He holds graduate degrees in public health and infection disease prevention. Mr. Booth holds a faculty position at the University of Florida College of Public Health and Medicine Residence Program and is a member of the FGI HDRC and ASHRE ASHE SSPC 170. Welcome, Robert.
Thank you.
One of our other speakers will be Timothy Peglow. Tim Peglow is the Associate Vice President for Patient Care and Prevention Facilities at MD Anderson Cancer Center in Houston, Texas. He joined MD Anderson in October 2007 with over 40 years of experience in all aspects of healthcare facilities management. He is a senior member of Operations and Facilities Management and manages the maintenance and operations of nearly 5 million square feet of space dedicated to our patient care and prevention. In addition, he directs the provision of all facility services consistent with the program objectives, priorities, and budgets established by the Executive Vice President and Physician-in-Chief and his leadership team. He is a licensed professional engineer in Indiana, has a Master of Engineering degree in Clinical Engineering and a Master of Business Administration degree, and is a member of ASHRE SSPC 90.1. Welcome, Tim.
Thank you very much. Glad to be here.
Jonathan Flannery is the Senior Associate Director of Advocacy at ASHE and manages ASHE's advocacy relations to federal agencies, code development organizations, and national professional associations that affect healthcare facility design, construction, and operation. Jonathan provides testimony, engages in deliberation, and develops public comments on proposed regulations to the benefit of ASHE and AHA members. Jonathan has over 30 years of healthcare experience and is a member of the ICC Committee on Healthcare, ASHRE ASHE SSPC 170 and SSPC 189.3, and NFPA 90A and B. Welcome, Jonathan.
Thank you, Benjamin. Glad to be here.
At this time, Jonathan, I have the distinct pleasure of turning the time over to you. Go ahead.
Thank you, Benjamin. It's a pleasure to be here, and I'm going to go over some introductory information and then turn it over to our experts on the phone. Wanted to just refresh everybody's memory about some of the terms that we're going to be using throughout this webinar and throughout the other webinars that we'll be doing later on. You know, the corona, and these terms are used quite often in the media also, and you'll hear people misuse them at times. So just want to make sure that everybody's aware that the coronavirus is a large family of viruses that cause a whole different type of illnesses, from the common cold to much more severe diseases like the one that we're experiencing now, COVID-19. The actual virus that causes COVID-19 is SARS-CoV-2, and then, of course, the disease that people come down with is COVID-19. I'm seeing some chat that the audio is fairly spotty, so we'll work on that and see if we can get that adjusted for you. One of the things I also wanted to cover was the COVID-19 community mitigation efforts that everybody's very familiar with now. Flattening of the curve, this has been a very important effort, and we, of course, played an important part of that in regards to helping to stop the spread, especially amongst healthcare workers, with many of the recommendations that we made throughout the time that this pandemic has been impacting us. It's important for us to continue to remember that as we go into a recovery status, that we still want to try to work on these goals of delaying the outbreak peak, decompressing the peak burden, and then diminishing the overall total cases and health impacts. It's important that we continue to do that, and some of the recommendations we're going to be sharing not only today, although today is going to be more about pre-planning and some immediate things that need to be done, but in the future webinars, we're going to talk about some of the social distancing and other things that need to be done through the efforts within the facility itself that can significantly help with continue this community mitigation. I want to look at the perspective of where we are with this. These numbers are updated from last night, and they're pretty big. You know, worldwide, there's been 271 total deaths. Here in the United States, we're over 76,000 deaths now. So there's been a significant impact. We want to make sure that we're understanding the impact that the healthcare physical environment does have when it comes to this pandemic, and that the things that we can do, especially when it comes to providing proper ventilation, providing proper social distancing efforts, providing the opportunity for staff to, you know, work in dedicated areas, those kind of things. Some of the recommendations that we've been making and will continue to make are very important for us to impact the spread of this. So, and as we begin to come out of this and start our recovery phase, putting together a recovery plan that addresses the ongoing local concerns is absolutely vital. We understand that there are still some areas of our nation that are just at the peak, some that haven't even hit their peak, downward side of the peak. So planning now and getting ready based on your local issues and your local concerns is really important. And we want to make sure that everybody's aware of that as we go through the 3 webinars over the next 3 weeks. We understand that not everybody's ready for all of this information, but we wanted to get it out there because we know some facilities are actually in recovery phases already and starting elective procedures and those kind of things. So we want to make sure that we look at the local concerns and issues. The other thing we briefly wanted to chat about was that this really has been a very different type of disaster that we're experiencing right now. You know, up to this point, most disasters have been fairly localized, haven't been too large, even when you consider some of the large like Hurricane Katrina, Hurricane Maria, Superstorm Sandy, and Hurricane Sandy, those, even though they were large and hit a large geographical area, none of them hit like this pandemic has, which has been a worldwide impact. So this, we still need to respond to these based on local issues, but it also does impact the worldwide effort. A great example of how that really impacted us was PPE, and the fact that the impact that China had impacted our ability to get PPE, which then forced us into doing some things that we normally would not have done. So making sure that we're aware of that and that we step back a little bit and understand that this type of a disaster has never really hit us, and it hit us on all fronts in all industries. I mean, the current issue, or one of the big issues right now, is the distribution of food and meat. This virus has impacted that. Normally you wouldn't see that. So it's important for us to step up with the leadership, that we look at modeling, and most importantly that we communicate. As always, in every disaster we've run into, we know communication becomes one of the most difficult and typically one of those things that we always need to work on. So with that, we need to understand that the recovery is going to be different than before also. We want to make sure that we provide, or we input proper planning and significant planning into the recovery. And how are we going to bring back deferred services? Is there going to be a secondary wave, and what can we do to prepare for that? How are we going to restore things not only as an organization but within our own department? What are these impacts to our capital planning, and what will be the new norm? Those kind of things we'll discuss at a later time in our last webinar, but we want to be thinking about those right away. With that, I'm going to turn it over to Robert now, and he will talk about pre-recovery planning. Robert?
Great. Thanks, Jonathan, for letting me work with you. We got together as a work group, or a task group last month. There are 6 sections that we put together. We're going to talk today. I'm going to talk about pre-recovery planning, which is where we are at right now. These are the things that we should really be considering, and we created really nice checklists and went through all the items that we have seen in the past. This is my 4th pandemic. I'm an infection control practitioner and have worked with as an infection control practitioner here in H1N1, MERS, and SARS, with Army and Korea during MERS. And a lot of these things we're going to talk about that we came up as a task group are things that we've seen in the past. We do expect to see some of these similar items come up. They are all important items that we want you to consider as a group and put together, and start considering them now instead of later, because they're going to eventually be an issue. Jonathan, how do I get the slides going forward? Okay, so make sure.
So that's down in the bottom left. Here, let me help you there. Okay, there you go. There's your first. Gotcha. And Robert, your audio is coming across a little rough. I don't know if you can get closer to the microphone or not.
Okay, so the first recommendation we have, and we've seen this in the past, is we want you as a group, if you're in facilities management or whatever, to be part of the big picture and make sure that you are part of the overall recovery team and understand what some of those efforts are. You should be involved with your leadership and see what their expectations are. The people that I've been working with and talking to over the last couple of weeks, as we start preparing for reoccupying spaces, really the leadership is coming back to facilities and saying, hey, what about this? What's your thoughts on this, and how are we going to do better? We recommend, as a task group, one of the line items is that you make sure that you're totally involved with the overall recovery efforts and you understand where this information is coming from. Here's a list of a couple items on this slide that talks about where some of these potential guidelines should come from. I live in Florida, so we just have some guidelines come out last week. We're in phase 1 of recovery, which is kind of confusing in some areas, but we got a plan. There are global and local forecasts that you need to consider, and so as a general recommendation, we made as a group that you need to understand where these guidelines are coming from, make sure that you have readily available information and modeling. The COVID-19 recovery ASHE site has some very good models listed in there. I look at them all the time, and that's where we're getting a lot of information other than the CDC and other organizations. So a really good idea is to make sure that you're part of that recovery planning. Next slide. Financial issues. As pre-planning and what we've seen in the past, and I can tell you by experience during H1N1, we did not have a vaccine until the end of December of that year, 2009, about 10 years ago now. We did not have a vaccine until October, so we did see spikes and issues occur. We did see influx in different areas of the country occur. And one thing that the facilities folks and administrative folks were having trouble with is getting their hands around those financial issues and projections of what the impacts are. We as a group feel that you need to develop a process now on how you're going to track those impacts and look at those issues such as additional utility costs and expenditures. Track your expenditures related to the COVID pandemic and what your recovery expenditures are. So if we do have financial reimbursement, we can actually have that. So now is the time to put that together, not 6 months or 8 months from now, and try to formulate that plan back and get that information. Put somebody in charge of that right now so that we can see what those are. Staffing issues. As I mentioned, I live in Florida, so every time we have a hurricane, we get stationed out of a hospital for 3 or 4 days, and then everybody leaves. We don't know if that's going to happen. There is reports of staff burnout. There's reports of potential layoffs. There's reports of mental illness and behavioral health issues and other illnesses. So one thing that the task group put together is that we need to really specifically put plans together and look at all the items that could occur during staffing, what impacts there might be to our staff. What if we bring staff back that were in other areas? How do we reassign those folks and make sure that they are educated as to the jobs they do? And then how do we provide employee assistance? I do a lot of talk, conversation with people up in New York, and one thing I find out is all the time when we talk about it is that staff are really getting burned out and that there's some occupational health and employee health things that really aren't being handled as they should. So that's one thing that we want to bring to the forefront during our pre-recovery, pre-planning. What are some of the things that we should consider? Facility preparedness and planning. This could be a number of items, but the one thing that we keep hearing about is what are we going to do about decommissioning spaces, and what are we going to do about reusing spaces as they are evacuated from COVID-19 patients. In Florida, we have a lot of surgery centers, and so a lot of surgery centers right now I'm working with 30 to 40, and we're talking about how we're going to reoccupy those surgical spaces and things that we need to consider. The thing that we as a group want you to consider and look at is right now what you're going to do about ramping up areas that were used for postponed elective surgery areas or used in other capacities. What are some of the infrastructure things that occurred that need to be corrected, and what about disinfection of those spaces? We commonly all the time get questions about what do we need to do with the HVAC system, what do we need about decontaminating and doing disinfection of the space, and that's very important. Should be considered right now during the pre-planning process. How about closure or underutilization of spaces? What those spaces that were shut down, that we didn't use? What do we need to do to get those spaces back in proper order? And, you know, we all hear about waterborne pathogens, disease, Pseudomonas, Legionella, other bacterial diseases. We need to, as a group, make a checklist, get with your utility people and say, what do we need to make this space usable again, or what were some of the limitations that may have put it at risk? Humidity, temperature, safety checks, and performing equipment checks for those areas. What are some of those underutilized areas that we are now going to reoccupy that were closed? Make a checklist, go through, do your planning, get your groups together, and make sure that everyone can come to the table and tell you what some of the things should be considered. The mechanical systems. A lot of issue has been discussed even over the last 2 or 3 months when we were looking at what do we do in mechanical systems and what, how do we achieve negative air and proper pressurization. Well, pre-planning and pre-recovery now goes back to what are we going to do to put those spaces back as to the way they were. How do we get those spaces back to original design? And are we going to have the correct pressurization, filtration, air handler operations as we did before to use as spaces for non-COVID-19? If you've read the CMS guideline that came out, I think it was, about 2 weeks ago, maybe a week and a half, you know, one of the things they bring up about building systems is that are we going to plan for non-COVID, non-emergent occupying our spaces and be able to prepare for a surge? This is you know, something real that we need to consider. We hope it doesn't happen, but history tells us that it does. And until we get a vaccine, the history tells us that we have potential for sporadic influx of patients in different parts of the country. Jonathan mentioned this has been very different than we've seen in the past. It has been. But we do know by history that we can have these things happen, so let's prepare now and not be caught off guard. Mechanical systems, if you're going to change them back, make sure that we have proper pressurization and air changes. And one thing the group came up with is if you're going to remodify or modify those spaces back, can we bring them up to current ASHE 170 guidelines and NFPA 99 guidelines to bring those up to current standard if you have older systems. Create a timetable and a plan to look at when you're doing your planning. Remember, we're doing planning, so we're sitting down, talking about things, making lists, and using checklists, which you will be provided in the COVID-19 recovery section of ASHE. We've created checklists to go along with these presentations, and today we're talking about pre-recovery and then immediate needs. Facility for reviewing your standard operating procedures and updating your information. We consider this to be an important topic that you go through and see what are some of the standard safety precautions that we need for employees, or just what are some of the precautions that we need to do by state guidelines or federal guidelines for people coming into hospitals. You know, we know hospitals are vulnerable. We know that we have visitors come in. We need to do masking. We need to set up stations. We need to limit egress and people coming in and out of those facilities. What are going to be the provisions for that? Talk to your infection control people. Talk to your administration people. A lot of times I hear that the facilities folks have this come back, get thrown back onto them and from leadership. So be involved and have representation with your leadership to understand what things are going to come up and what you need to be considering. What are going to be some screening provisions for patients, cleaning and disinfection practices, visitor restrictions, and obviously social distancing and building system guidance. So these are some of the pre-planning things that we really, really, really want you to consider. I'm going to turn it back over to Jonathan. I think Jonathan, or is it Tim's going to go through the specific facility management issues?
Yes, actually, Tim.
Thank you, Robert. This is Tim Pegwell. I hope everybody can hear me clear. I know the audio has been a little bit of a challenge as I've listened to the presentation as well. I'm going to talk a little bit about the specific management issues and try to help people get started. This is great timing for me. We've been in this for about 2 weeks at MD Anderson, and I'll share some of our experiences here. Please realize, and I think we've continued to reinforce, this is a local situation. Everybody's impacted a little bit differently, and it probably will change on different frequencies, ramping up and ramping down over time, and it all depends on your individual situations, and I know some of your resources. So one of the things I think that always is on the top of your mind is realizing that if you did take some waivers, you're going to have to turn those off at some point in time and return to normal operations. So hopefully if you did request a waiver or are you using them now, please, I would strongly suggest everybody document them on their list so that then you can make adjustments and make sure you don't miss some of the time windows on the list. The ASHE Excel sheet has great checklists on this. You may also make sure you're keeping in line with your state and everybody else, because I know this is something that in the moments can easily be overlooked. There's a lot going on and a lot of pressures in a lot of different areas. One of the key things we know, and I know we did a lot of this, is a lot of alterations to accommodate the COVID patients. We created 4 floors of rooms specifically geared for the COVID patients and did a lot of ingenious things that we're going to have to redo, turn back, undo. We've got a long list of those. We've also know that we did some individual scenarios involving partitions and et cetera to segregate or separate the COVID patients, and we're going to be doing some assessments on those and with plans. But once again, we've created detailed lists of how are we going to manage some of those. We are doing aspects of zone maintenance. I think we're probably like everybody else. We all know there's going to be surges of work. I can tell you right now our current workload being in the downward phase, about a third of our work orders requests by our people in the clinics and the hospital went away. So we are going to look at that carefully on how we bring those back online, but still realize we've got financial targets we're going to have to hit. As our census is now low, we are starting next week to go back up and what I call ramping back up of our operations in our clinics. But we do know there's going to be some financial limitations, and we're going to have to balance demands with cash available within the organization. So one of the things we do know, we did create 120 some negative pressure rooms, and for us, our rooms have been always slightly positive since we're 100% cancer, and we wanted to keep as I best describe it to some of the people, we wanted to keep our patients protected from the staff versus now we're having our staff be protected from our patients. We also created ante-rooms in surgery, interventional radiology, cath lab, and multiple spaces of that at the request of many of our physicians so we could treat the COVID patients. We'll have to undo all of that work and track that and return it to normal operations following 170 principles. So we've got quite a long set of lists that we're going to work on as we start to develop that plan. We're going to try to create time windows when we do this. What are we going to do in the next 30 days? What are we going to do in the next 60 days? Where do we think we're going to be in 90 days? Realizing that each of those plans probably will have to have some alterations or ability to flex depending on what's going on in the area. and be able to react to the needs of our patients and the local rules and regulations. We are in Texas right now in partial reopening of the state, so we are watching, are we going to get a second wave or not, and how are we going to manage that within both the state, and how are we going to respond within our hospital, because we know that has, once again, significant impact on us. A couple things is, like I said, is how do we create all the accountabilities to begin to do this. We know we have some separations between our COVID patients and our non-COVID patients, or our suspect patients. So how are you going to do those? How long are we going to keep COVID patients on a separate care track versus mixing them? I don't know that answer right now, but we do have those plans, and we are very carefully looking at both our clinics and everything else. We do know for in a couple areas, we are going to do testing on all our surgical patients for COVID, particularly scheduled ones, so that we can reduce the potential contamination or fear of doing the aerosol-generating procedures associated with anesthesia. We do have a number of procedures. I do have accountability for housekeeping, so that has been quite a challenge on how we manage housekeeping. It's been a tremendous demand for services. One of the things we have done is we did create an institutional reassignment pool or reallocation pool, and we are using some of those people to do what I would call low-tech, high-touch cleaning in our waiting rooms, exam rooms, and some of our common areas, and to disinfect places. And it's been a real positive feedback from both our employees and our staff. The other thing we had to do was develop procedures for what do we do when we have employees who are COVID positive. So I'll also answer one question that's come up. The CCZ, that's COVID positive areas, and NCC are areas that would be under concern for having patients that are COVID that might not be tested. So we continue to work on all of those. We do have aggressive terminal cleaning schedules. We do use pulsed UV in our areas and use that as we clean rooms that are contaminated. We do have a regular program of ventilation preventive maintenance programs. We're continuing to use that. That was a great outcropping of our more recent surveys we had with Joint Commission, where we've really been looking hard at our rooms for both airflow, pressurization, et cetera. So we are looking right now at plans on how we're going to prioritize work coming out of the COVID situation for both maintenance and housekeeping, because the demands are huge. We are also going to be looking at it as we determine how do we slow down some of our cleaning and be able to manage that effectively and return to a level of what I would call pre-COVID crisis cleaning. And that's going to be a critical decision with our leadership team. All this is being developed with clinical leaders, physicians, department leadership, so it's not in a vacuum. And I think a lot of the things that we've discussed, some of them may be applicable to your organization, some of them may not, like I said, depending on what you do and how you do it within your team. We do know that there's all kinds of specialty vendors. I think everybody is looking at what they can do to help, and I think careful care and consideration needs to be thought about as you begin to look at those and what's going to work for your situation and what's the quality of work. I also know some contractors that prefer not to work in COVID situations. The other thing we look at is we are screening everybody that comes into our organization, which does include temperature screening, and we do include that with contractors, so nobody can come into our organization without going through some of our screening areas. That's something that's going to be a huge consideration as we go forward, is how aggressively do we screen, till when, and help and manage who's in our facility and really limit the numbers of people within our facility at this point in time. If you have alternate care sites, how are you going to work those in? Those could be anything from ambulatory surgery centers, depending on what you might have done with alternate sites. On temporary shelters, we've got a temporary space outside of our ER that we were using for triaging. We still have in place, but the myriad of, we also have some drive-through temporary testing sites in place, and at what point in time are we going to dismantle all those and move those back to what I would call typical facility operations. All that's going to be part of our plans, and we're watching data carefully, and we'll be looking at utilization to help us decide at what point in time do we decommission those efforts and return to more of our routine business that we were doing pre-COVID. I have no timeline on that for what we're going to do. We are working to capture information as we have on this slide. I think we will do some updates on our emergency operations plans. We are already in place with capital expenditure reevaluation, reprioritization. For both this fiscal year and next fiscal year, all construction projects have been reassessed, and we've pushed out a number of them just to allow us to effectively recover and consider options such as space availability, access to space. We know that's going to be a challenge because we do expect some of our clinics and departments to expand evening hours, or also go in and do some Saturday work as well. In our organization, as the leadership has said, COVID's been great, but unfortunately all other illnesses didn't take a time out, so we do have a fair amount of catching up to do on surgical procedures and other medical procedures. We are routinely recognizing the staff. One of the cool things about what we're doing is we have a daily video conference with leadership every morning for a half hour, and we do a shout out to the staff as part of that. So some of the people both in direct patient care and supporting care may get on the shout out list for just some of the great work they're doing every day within the organization, being part of the team. All right, some of the immediate need items that we need to begin to look at. Once again, I would strongly consider everybody to go onto the ASHE site and get the Excel sheets and use those as a guide. There's a lot going on. I think it may expand some of your thoughts as you begin to use some of the checklists to help you solve problems. We know we're all going to have staffing level issues, particularly with the financial situation that I would believe most hospitals are in. So what is your staffing level? How do you work and communicate what your priority of work is going to be, both COVID areas, non-COVID areas? We track our work weekly. I update our leadership team regularly on what our backlog is and our deficiencies. We track through our safety committee all our compliance on preventive maintenance. So that will have to continue, and we'll manage those accordingly. I'd suggest everybody take time to make sure that some of those communications occur within your organization with the dynamics of the finances as well as accreditation surveys, et cetera, that we all need to manage every day for what we're doing. We are reviewing each one of these systems for prioritization, we would put all these on our top priority lists of what we need to maintain and have to have our preventive maintenance programs running full bore with each one of these systems to make sure they can do their needs, as they're almost all of them critical to the operation of the facility. And we will continue to manage them accordingly. At this point in time, I'll turn it back over to Robert and let him take it from here to the end. Thank you. Thanks, everybody.
Great. Thanks, Tim. Boy, I'm reading some of the comments in the chat session. A lot of good questions. I'm hoping that we can answer some of those at the end. Demobilization and what we should consider under immediate needs as we start to, as I mentioned earlier, and as Tim has mentioned, about cutting back resources. One, obviously, we want to follow our ICRA process, our infection control risk assessment process, and one specific item of concern for me would be, do the contractors or the workers understand what their organization's infection control requirements are for taking down barriers, removing barriers, and what some of those processes are so we don't cause other issues for our patients. What are the cleaning processes and criminal cleaning provisions that we need to consider? And also the allowable proper clearance time. You know, as infection control, we look at infection control across the board. We also are really engaged with the infection control practices for construction. I have a clinical and a non-clinical background, so come from a family engineer, so I understand what you guys do, and I do it as well, but sometimes our infection control nurses don't. We do need to make them feel comfortable and happy that we are doing these things right. So what are the processes we're going to use and how we're going to use those clearance times? There's some very good data provided by CDC on clearances based on air changes. And then interim life safety measures as well, you know, the fire protective measures that we put into place, how we're going to take those out, take them away, or continue to have those during this process. Deferred maintenance and completion of that deferred maintenance as we take these spaces back over. Has that been done? Has that been corrected? Are we able to use this equipment? And the turnover of the space, has that been done appropriately? One thing I do want to mention is let's don't create another disaster when we're doing this demobilization. And what I mean by that is, how many of you had a contractor knock off a sprinkler head? Or how many have you had a major water leak during some type of construction project? So take that into consideration. I've seen that twice over the last 2 months during these setup processes. We need to really consider that that could be a potential risk, and we don't want that to happen to our facility as well. So things for you to consider. And then immediate needs for additional considerations that the group, we feel that you need to understand. And we're getting this from past history, and we're getting this from hearing our partners and our colleagues. Debris removal and waste management. Let's don't put waste and trash next to an outside air intake or next to a front of the entrance of the hospital. Let's manage that appropriately like we did before. Is there going to be any environmental remediation and cleanup processes? And are those people that are going to do that, are they competent? Are they doing that right? Are they not going to cause other issues for our staff and or our other patients? Do we have space for storage of supplies, patient belongings, personal effects? Are we going to continue to have mortuary storage in areas for morgues, temporary morgues? A lot of people are still struggling with this issue as we speak, and it's not going to go away. It's not going to just go away. We're going to have to consider what we're going to do. Even if we have a major downswing in cases and deaths, we have to think, what if we have an upswing, what we're going to do about that. So That was one thing that we put in the checklist that you need to make sure that you keep your hands around, because your leadership's probably going to ask you about that. And then one topic that just keeps coming up, and we had a conversation the other day with another group, is PPE and storage. Most likely, your leadership's going to come back to you in facilities and say, create storage areas for this stuff. And as we get more and more equipment brought in, whether it's ventilators or PPE or other equipment for patient care for a potential influx, where are we going to store that at? Some people in different states have been getting really clever ideas where they're going to get with their local hospitals. Where I live, we have maybe 40 hospitals around the whole area. I know Tim's out in Houston where there's a lot of hospitals. We're talking about setting up centralized storage areas so we don't overwhelm each facility. That might be a consideration that you get with your local emergency management people and make those considerations. And then lastly, supply delivery as this comes on. We can still do that right. We're going to still do that in a safe manner, and we're not going to have a lot of stuff on the loading dock that's going to get damaged or stolen or affected. Those are the checklists. Those are the two checklists that we are discussing today, and as a group, and I know Tim and Jonathan and the other members have been working real hard on these checklists. We recommend that you go and get those spreadsheets and those checklists and go through and see what your shortcomings are. Do your gap analysis, your analysis of where you're at, what you need to do, what you need to consider, and don't do it alone. Make sure you get your subject matter experts involved and have those people around you to say, wait, you didn't think about this, because past history has shown us that we've just done that and we haven't really considered a lot of things. So I think the group came up with a really nice list of items in that we're putting out to you as a group now to understand. Jonathan, do you want to talk about frequently asked questions?
Yes, thanks. Really appreciate all the information, Robert and Tim. Great job. We prepared a few questions that we've seen a lot on our ASHE community, and then we're going to try and get through these pretty quickly so that we can address some of those chat questions that have come up. One of the big things that's been going on in the ASHE is, do I need to disinfect the HVAC system in units converted back from COVID-19 unit? Based on the CDC guidance and the scientific journals that research papers have been put out so far, ASHE is recommending, and we have this on our frequently asked questions web page. So under our COVID-19 resources, you see there's a frequently asked questions section. If you go to that, we actually mention what needs to be done in regards to cleaning the HVAC system. There really isn't any necessary additional cleaning than air changes per hour. The room needs to be terminally cleaned, and that includes all the grills and every surface and all that, the room where the patient was. But what they're finding is that the airflow, if the virus gets into the ductwork system, all the airflow desiccates that virus fairly quickly. So if you follow the CDC's guidance on making sure that you provide the appropriate number of air changes per hour within the system, you're going to be okay on that. The other thing that I want to point out there is filters. We've had a lot of questions about filters and whether they need to be changed out. They don't need to be changed out specifically because they were used for COVID-19 to serve an area with COVID-19 patients. They should be changed out based on your standard facility policy and procedure. There is a bit of a concern that if the filter is dropped, it could knock some of the stuff off the filter. So using a fixative on that is probably a good idea. Not totally necessary because most of that would be desiccated again and won't have any virility, but it wouldn't be harmful to spray it with like a hairspray or something of that nature to be able to fixate the filter. Robert, you want to handle our second question? Will there be a second wave?
Well, as I mentioned before, history tells us there could be. If you look at the last 6, 7 pandemics that have occurred in this century, just about every one of them has a second wave. Currently, we have no vaccine for SARS or MERS. We do have one for H1N1, which is really a result because of the 1918 flu, or Spanish flu they call it, was H1N1, and we've been studying it for years. So we were able to get a vaccine in a short period of time, as I mentioned. We still have a peak or a second peak occur in October. H1N1 occurred around April 2009, and we had a second peak in October. And with that vaccine coming out in October and November, then we were able to eradicate it fairly quickly. As you mentioned earlier, COVID-19 is actually the disease SARS-CoV-2, which is the virus that causes COVID-19. Is the one that we test for. There is no vaccine for that. So, we hope there isn't, but that is, as you mentioned, this is something different, and people have really been doing some good social distancing and wearing masks, but we may not have a strong peak. Who knows? I can't answer that. But we do need to expect that we might have sporadic increases in different parts of the country, and we need to be prepared for it.
Thanks, Robert. Tim, you want to handle our next question. What will the long-term impacts be?
I think there'll be a couple things. One, I think people will look at how they set up units to handle things like COVID. I know here in most of the hospitals I've worked in, they had scattered rooms, not a cohort unit. So one of the things I think people will probably look at is cohort units. I like the suggestion on the line, and I know or in the chat box. I think telemedicine will be different. I think it's going through a lot of review at the national and state levels, and it's going to really take some leadership for that to occur, because right now, with it being regulated at the state level, there's some states that just will not allow it. I'm hoping it's a tool. Our medical staff has been using it quite frequently, and I think some of the patients really appreciate the interaction that it provides them without having to come into the facility where possible. We'll just have to, like I said, wait and see where that goes. I think there will be some design changes, but once again, with this kind of thing only happening every 5 or 10 years, I think it's going to be real difficult to make those changes quickly. But like I said, it may change how fast or how people book and how they manage sizes of waiting rooms. We're also looking more aggressively at work from home and how much of our work can be done in different settings. So I would say that's probably going to be another year or two before we know what those longer-term impacts are going to be.
Appreciate that, Tim. We did get a question through our website, and you can find, again, the ASHE.org COVID-19 resources website. On the right-hand side, about a third of the way down, there's a comments, tips, or question access form, and you can submit them there. One of the questions we got from there was in regards to what should be done in regards to cooling for temporary sites. We know with the upcoming weather, it's going to get warmer, and when people are at temporary sites, there needs to be, they need to be taken care of. There are really no standards or code requirements in regards to those type of sites. OSHA has some very good information on their website in regards to working outdoors and heat, working in temporary sites. So we have again, a frequently asked question to this on our web page under the frequently asked questions under staff safety. That gives you all the OSHA links and recommendations. They use a heat index form that gives you guidance on how much to provide for folks. The other thing that we want to make sure people know about that is the fact that it's real important when you're figuring out how you're going to provide cooling for these type of sites that you include infection prevention in this. The last thing you want to be doing is providing cooling to help protect your staff that could impact spread or some of that nature. So just make sure they're involved with that discussion and are okay with what you're doing there. Of course, most of the rented temporary facilities, they come equipped or can come equipped with ceiling fans, misting systems, all kinds of stuff. So work with the folks that you have there that you're renting that from. So that's a great resource for you there. I know in the chat we had some question. We had a question early on about social distancing. Wanted to address that one real quick. Again, on our web page, we have a document about recovery, and it references the CMS Phase 1 recovery. In that, we have recommendations on how to set up queuing lines. One of the things that we're really concerned about or have seen in many places is people think about putting the line on the floor that tells you to stay 6 feet away from the person in front of you, but then they don't spread out the cords or the dividers so that I'm standing right next to someone on the other side of that divider, which isn't 6 feet. So you need to make sure there's 6 feet all the way around when you're doing queuing lines. And we actually have a graphic on our website that shows how to set that up. And then again, waiting areas is another concern. Taking and making sure that you have plenty of space around each chair and reducing the chairs in the waiting area. I know there are concerns, how do I make sure? Well, that's where your administrative controls have to come in play. You shouldn't load up your waiting room. You should keep it fairly light through your administrative process, through appointments and those kind of things. One of the things that is extremely difficult is elevator occupancy. That is a very tough one. We've had people who have taken and recommended taking and having someone actually monitor the elevators and how many people can get in. So, and during your rush times, that is extremely difficult. CDC recommends encouraging people to take the stairs, so that is a good thing. I see someone's looking for the queuing line graphic link. I will put it in the chat box as soon as we're done here. Tim or Robert, do you have any other questions that you saw in the chat you would like to address?
Yeah, I saw the one on the outdoor air, and I agree with what's going on in the chat box. I don't see any big push to increase outside air in most situations. If people are within the 170 range, I think everybody's going to be fine. I would agree if you're particularly in the hot, humid areas, you may not have enough cooling to deal with increasing your outdoor air to your system. Particularly me being in Houston, that is a very difficult challenge for us to control humidity, and that would create some significant problems. So I think people need to be careful on what they read and understand and work with professionals that you may work with on the engineering side, or ask questions as this starts to become, you could create more problems than you're going to solve. So good question.
Yeah, Tim, I'll mimic that. I apologize if I've heard that the audio is difficult. I apologize for that. Yeah, a lot of good comments. And, yeah, Tim, where I'm at, in Florida, we have a lot of humidity, so that's always a concern. I did see a comment about nursing homes, and that is one of our major concerns. We're currently seeing 25 to 30% of the deaths in New York and other states are in nursing homes. So if you have nursing homes under your service, need to make sure that we continue to provide protection for those elderly patients that are at risk. And for cooling, we've used spot coolers and other cooling provisions in the past, especially when we've taken over spaces that don't have HVAC systems that are appropriate. But, we just need to think this through and see what we can do to provide appropriate temperature control and humidity.
Thanks, Robert. We have hit the top of the hour. Do want to mention that we do have 2 additional future webinars on the same topic. Well, not the exact same topic, on recovery, I should say, where we'll discuss on Wednesday next week short and long-term and ITM needs, and then on Tuesday, May 19th, sustainability and the new norm. We appreciate everybody, and for those who participated, and especially for the great information in the chat, and we will talk to you on the 13th. Thank you very much.